youth presenter today. She very graciously agreed to come and talk to us on the HIV epidemic in Louisville, but just to give you a few words about Dr. Schulte. She is director of the Louisville Metro Public Health and Wellness. We're really lucky to have her come in today. She has a really impressive background and a real depth of experience. She has worked as an EIS officer over many years, has worked as a medical epidemiologist.
Take out the many.
I don't know. We should be proud of that. So it is been a highly varied background with a very, as I said, impressive background and depth of experience. So in addition to her MPH degree, she's also board certified in pediatrics as well as preventive medicine. And she has, as I've said, worked as an epidemic intelligence officer for students who might be interested in doing that sometime in the future. You might want to ask her to ever be open to talking to you about it and her experience. She's also worked at the National Institutes of Health in Bethesda, and then prior to coming to Louisville, she served as medical toxicology fellow at the New York, Texas Poison Control Center. So she's got really a vast array of experience. We're very lucky to have her here today. Thank you very much.
Thank you. This is kind of a current state of the assessment of HIV in Louisville, and I think there's some surprises. I know I was surprised when I got here and learned some of this stuff. Okay, so our objectives are to understand how the epidemiology of HIV and AIDS has evolved, to take a look at what the impact of opioid and heroin is on HIV epidemiology, to understand what the risk groups are and how their behaviors have changed, to understand opt-out testing for HIV, to understand the issues in funding expanded HIV and hepatitis C testing, and to comprehend the role of active surveillance, i.e. you don't know if you have an epidemic if you don't test. So there are, when it comes to HIV, there are three big modes of transmission. There's sexual contact, which is both heterosexual and homosexual. There's parenteral transmission, which is primarily among injection drug users. But a long time ago, this was something that was worried about when, before hemophilia had been cleaned up and the supplies to that, and there was contaminated blood supply, also blood transfusions and needle sticks. And then there's vertical or perinatal transmission. So HIV in the U.S. now, there are about 1.2 million people estimated to be living with AIDS. There are about 47,000 new diagnoses estimated to occur annually. And it can be considered a chronic disease with appropriate drug therapy. An estimated 660,000 Americans have died from HIV/AIDS. And the death rate, and this is after the drugs came along, has declined, for many causes, declined from 6.2 to 5.5 deaths per 100,000. And now new cases are geographically clustered in the South. The risk groups now really are men who have sex with men, persons of color, and people who use needles to inject drugs. And the first and third groups on there have a lot to do with shaping what's going on in both Louisville and Kentucky these days. So the historic aspects of it is that we're now in the third decade with an estimated 35 million deaths globally. And in terms of how bad this is as a cause of death, it ranks up there with the 1918 influenza pandemic and the bubonic plague in the 14th century. And to give you an idea about the bubonic plague, it's estimated that it wiped out 40% of the European population during the Middle Ages. And there have been some wins. Some of those include the diagnostic assays, and that's important because it means we can diagnose it and do it faster. One of the things you'll be hearing about a little bit later is some stuff that we want to do to expand testing, and the ability to do that is really based on the fact that there's tests you can use in the field now. There's prophylaxis of opportunistic infections so that people don't develop and die within months to years, which was the norm when it started. There are effective drug regimens at controlling viral load. And there's the biggest one has probably been the prevention of perinatal transmission. So issues for Louisville are that many of the drug treatment programs here, and you think about this, how often you hear about the drug overdoses, every other night on the news or every week in the paper. So there are a lot of drug treatment programs because of our problems with the heroin and the opioid epidemic and the ER. So both of these programs do limited HIV testing, and this gets into the idea, how do you know if you have a problem if you're not testing and looking for it? And so the ideal process for this is that you do something called HIV opt-out testing. And back in 2003, CDC came up with some recommended guidelines for it. And basically, we'll talk about those a little bit more, but basically when you go into the hospital or you go to the doctor's office, you sign a consent form, and it's part of routine testing. In other words, you have to specifically say you don't want it. And the problem here is, right now, you have to specifically say you do want it in the drug treatment programs and in the ERs, and we'll talk a little bit more about how much of this goes on with specifically the injection and substance abuse issues. And so you really need the testing to identify any outbreaks. And hepatitis C testing is also needed, although that's not going to be the focus of the presentation today. So some of the older aspects of HIV and intravenous drug use, it was a known risk factor for HIV in the early days of the epidemic. They used to have a series of H's. It was hemophiliacs, a bunch of other stuff, but included in there was heroin. The HIV transmission has been associated with earlier use of heroin, crack, and other drugs. And IV injection, we'll be talking about this, is a very efficient route of drug administration for heroin and other injectable drugs, and it produces a strong drug effect at the least cost. In other words, you're getting high cheap. One of the things that drives a lot of the substance abuse profiles is that they start out by getting diverted drugs out of the medicine cabinet, from mom, dad, or their doctor prescribes them too much and for too long, which is also frequent. And then if you're starting to do that every day, you're going to end up spending a couple $1,000s easily with what you use. Heroin's cheaper, so you're going to shift to that. And there's kind of a perceived pecking order among a lot of the people who use drugs, in that, if I just take a pill, it's no big deal. And then it can evolve into snorting. And gradually, as the craving or the dependence or the addiction, whatever you want to call it, grows, the fear of needles fades away. And the sad thing is that people who often start out middle class end up very poor, as their need for the drug just continues to evolve, and then they get onto heroin. And then the high-risk situation we're going to be talking about, Austin, involves the reuse of needles and syringes. And then, not so much here, but historically there were shooting galleries where you could go into a place in New York City or Boston or wherever on the East Coast or the West Coast, and you just, got needles there and you shot up. And then in some cases, if you were afraid to do the injections, there were hit doctors who would do the injecting for you. And obviously none of this was with sterile needles or syringes. And another aspect of this is, we talked about the earlier use of heroin and crack. In the early days of HIV, when the drug use was an issue, it was often in minority communities. And I think it's fair to say that a lot was ignored when it was a problem among those populations. But now that it's a suburban thing, and in the white population, all of a sudden people are paying attention to it. So there's a matter of some health inequities in this. And in a way, though, the communities of the black population, Hispanics in some areas, they have a history of this, so they know a lot more about what the HIV risks are associated with that. They know it better. I think it's fair to say that until 3-4 years ago, when most people thought of HIV here in Louisville, they thought of sex, and they didn't think of shooting drugs as a way to get it. So some of the newer aspects of HIV and the intravenous drug use. The HIV epidemic back in New York City in the 1980s was the biggest. And then it was estimated that 60% of all the people who use needles to inject drugs, that was 60%. So if you were using, there was a good chance that one of your needle sharing partners or your sex partner was positive through this. And now that they've implemented the syringe exchange programs, and they did that a long time ago, it's down to 15%, probably at the highest, maybe 10%, but it's still there. And the syringe and needle exchange programs you'll be hearing about, because we have one here, obviously, across the street in Louisville. And they were important in reducing the prevalence. And the current opioid epidemic has spread to upper income and suburban areas. And the newer drug users seem to be unaware of the HIV risk associated with that. In a way, they just didn't think about it. And then there are poor surveillance efforts to date. You have to test if you're going to find out if you have a problem. Factors associated with HIV transmission through needles. There are occupational studies done that estimate the transmission risk per episode is 0.2% to 0.5% on hollow bore needles. And the risk of occupational transmission, now we're talking like nurses and that kind of stuff who get an injection in the hospital, increases with the size of the needle, the amount of blood in the needle or the syringe, and the viral concentration depending on where the person whose blood was, where they were in their infection. And HIV can remain viable for up to 42 days when the syringe contains the virus. And the transmission risk can increase when users register. That's when they check for a venous splash into the syringe. And the risk also increases with the shared use of cookers, filters, and water used to mix the drug. That's all. And the more of those you do in general, the greater the risk is. And then injection drug use is estimated to account for a third of the HIV cases overall, and this is historic, either directly through injection or indirectly. In other words, your sex partner is somebody who's a drug user. And that combination of factors, you can see, is an issue in Louisville, given what we have with the opioid epidemic. There was an article that was published in the 80s from DeJarlis, and this is based on data from the Northeast U.S. that showed a 70% reduction in HIV incidence or new infections among drug users after the syringe exchange program started. And those programs were mostly concentrated in the Northeast U.S. and in California until fairly recently. And major changes in illegal drug use and the diversion has obviously produced a much larger at-risk population. So the racial and ethnic minorities still have disproportionately high rates of HIV infection. The 2012 incidence of 56 per 100,000 was among African Americans and 19 per 100,000, I missed a zero, among Hispanics. 80% of the HIV AIDS diagnosis in adolescents and male were in men, primarily men who have sex with men, and that's true here. We'll be talking more about that. And these are the lifetime estimated risks of HIV infection depending on by what group you're in. So among MSM, it's estimated to be 1 in 6. Among women who inject drugs, it's 1 in 23. Among men who inject drugs, it's 1 in 36. Among heterosexual women, 1 in 241, and among heterosexual men, 1 in 473. Now, if you combine the MSM and the men who inject drugs, they have an incredibly high risk. This gets into the efficiency of HIV transmission. And this is from an article that CDC put out about 2 years ago. They took a look because stuff had changed, the viral strains had changed. And they're taking a look at what your risk per 10,000 exposures is. And what I want you to pay attention to is, okay, this is if you got a blood transfusion. This right here is if you're needle sharing injection drug use. This right here is the high-risk sexual exposures, receptive anal intercourse and insertive anal intercourse. And what matters here is both with the needle sharing injection drug use or those two forms of anal intercourse, they tend to be activities that are repeated again and again and again in a couple of days. And we'll talk about that as it relates to Austin, Indiana in a little bit. But I want you to just think of receptive anal intercourse is the big risk, and then needle sharing. So where are we for HIV here in Louisville in 2016? On average, there are 15 to 16 new HIV infections in Kentucky each month. 12 to 13 of those are in Louisville. Now, there hasn't really been a change in the number that we're getting, but there's starting to be a shift in among that 12 to 13 who are the people. And as in the U.S., transmission among men having sex with men had been considered the dominant mode of transmission, but the intravenous drug issue clearly merits some increased attention. And we're going to talk now about Austin, Indiana. I'm sure a lot of you know about this. This is the place that's 30 miles away and what led Dr. Moyer, who's sitting here in the first row, to be important in getting the syringe exchange established here in 10 weeks after the law was passed. Okay, so this is from the New England Journal of Medicine late this summer. And here's the epidemic curve, and there's two things I want you to pay attention to. This is when they had 35,000 syringes dispensed, and this is 77,000. We're going to come back and talk about that in context of our program here in Louisville. But what happened was the first stuff was suspicion was among the DIS, or the disease intervention specialists, when they noticed HIV infections in this rural county, and that was that was an unheard of event there. It just didn't happen. And then this is the epidemic curve, and the amount of time and effort it took was incredible. If we were to have a big outbreak, I don't even want to think about what it would take. So Scott County is across the border. Its population is 24,000, and they had had 5 HIV infections reported in almost a decade there over in that county. And then toward the end of 2014, early 2015, they had 8 new cases, which should have raised some eyebrows and fortunately did. So they, like Kentucky, have had an issue in terms of huge increases in the rate of drug overdose deaths and a 10 times increase in opioid-related deaths. Their opioid prescription rate per 100 persons is 109.1. Their drug overdose deaths exceeded the motor vehicle deaths in that state, and that's true nationally now. If you think about people dying from injury, you're much more likely to die from a drug overdose because you've injured yourself than you are in a car accident. And Indiana was ranked 16th for drug overdoses among the 50 states, but obviously you've heard this story in Kentucky as well. So a little bit more about Austin. It's 4,200 people. They had at the point that this outbreak started, they had a 10% unemployment rate. 20% were below the poverty line. 21% hadn't graduated from high school. And they ranked 92nd among cities in Indiana in a variety of health and social indicators, including life expectancy. It's a pretty depressed town. So their drug use patterns were that this is a town of 2,400, and 500 are using syringes and sharing. And usually it was multi-generational, or I shouldn't say usually, often it was multi-generational, where it's mom, dad, and the kids, or the grandparents and their kids and other relatives. And they would inject 2 to 20 times a day. Now the slide I showed you before talked about what your risk was per injection. So you start doing the math here, and you can see why the risk would go increase. And so the people who are at risk were their syringe sharing partners, their sex partners, and social partners, because the social partners were often recruited into drug use, and they commonly shared equipment. That knowledge that we talked about was missing. They were in many ways a naive or uneducated population, because we had DIS from Louisville who went over and worked this, and they said people were absolutely shocked that you could get HIV through a needle. And so this is kind of the onset of the outbreak. There were 3 new HIV infections and then more. And then 2 months later, the state calls in CDC, and there was a public health emergency declared. And it was shortly after that that they were able to start the syringe exchange. In the way Indiana was set up, you had to have a public health emergency declared before you could really do any syringe exchange. And then this shows you what happened by March in terms of where the cases had gone. So I said earlier that there were 5 cases during a decade. Now we have 55 in 3 months. So their infected population, the median age was 34 years, 58% male, 100% non-Hispanic white, a new risk group. 92% were co-infected with hepatitis C, and there is a high poverty rate and no health insurance for many of them. And so meanwhile, across the bridge here in Louisville, this is when Dr. Moyer had already been working, but this was when she swung into high gear and went into a bunch of hearings to get the legislation passed. And we had the syringe exchange established in June 2015, 10 weeks after the state legislation was passed. It's all supported by local metro funds, and it's staffed by certified drug and alcohol counselors. And that's a big deal. We'll talk about that in a little bit more. And it started outside in a trailer, and early this fall it moved inside into the health department. And there's also some remote sites where people go out and can get services in the field. So the goal is to reduce the transmission of HIV and hepatitis C among people who inject drugs, among their sexual partners, and their newborn children. And people sometimes ask us, well, what about their newborn children? Well, there's been a baby born here in Louisville to a mother who was one of the injection drug users there. And I think that and another case are the first cases that have been in infants in Louisville in a long, long time. And so the strategies include providing sterile syringes and HIV prevention supplies, safely disposing of the syringes, testing for HIV and other bloodborne pathogens. They're asked to do that. That's not mandatory. And to educate and distribute materials on syringe exchange, safe injection, and overdose prevention. In other words, to make sure they know about Narcan. And then to refer and link the participants to drug treatment services, other health services, and social services. And I think that's a surprise that many people have, that we would need that, because you've got an issue here where I've said many of these people started out with insurance in the suburbs, and it's a rude awakening as they get poorer and they need access to health care. So this is a map, not the most recent map, but it shows where we draw from. So here's the border, the river, and you can see we're drawing a lot from the metro area. And then over here from Indiana, and then this is Kentucky overall, but you can see how far we're drawing from. And we've handed out 538,000 syringes since June 2015 when it started, and the clients have turned in about 378,000. And our policy is to permit clients to have the multiple devices at one visit, with the idea that other users will also receive clean syringes and will reduce exposure that way. That's been controversial with some of the legislatures, and they want it to be a one-for-one exchange, but we disagree with that, and that's probably going to be another battle in the legislature this upcoming year. So these are the one-year stats for our syringe exchange. There were 13,000 visits, 3,600 new clients, 1,700 return clients, and at that time there were a fewer number of syringes provided because it was only 1 year. What I showed you before is the most recent totals. The average age is 33 years, which is not that dissimilar from what I told you about Austin. About 63% are male, also not that dissimilar from Austin. And then 91% are heterosexual. And then what matters here are what their drug of choice is. It's overwhelmingly heroin, but you can see the other drugs that they use. And the methamphetamine is an emerging one. We hear now on the streets that if you buy heroin, they also offer you meth. And then there are issues about risk, and this gets into what we were talking about with the need to test. And this is 2015, CDC did this, and they were basically taking a look at what counties are vulnerable to an outbreak of hepatitis C and HIV, similar to what they had in Austin. And the 54 of the counties are in Kentucky. They're in green. And the red dots show as of the time that this was done and came out last summer, who had a syringe exchange program that has obviously expanded since then. And so why should we worry? Because Louisville isn't on the map. I've had that said to me. But this is a place where people either come to shop or party and celebrate. And if we think it's not common, in August 2016, we had a 24-hour period where there were 24 heroin overdoses. So obviously we might not be on the map, but we're still at risk. And to be honest, we're not doing such a great job of HIV testing. And I want to talk a little bit about HIV and active surveillance and passive surveillance. Passive surveillance is the health department makes a condition reportable and people report. Sometimes it's from a lab, sometimes it's a doctor's office, but you see what happens. And then there's active surveillance where you're going out and beating the bushes. And that's what happens when you detect an outbreak of something. And what we're trying to really do is to push this area and the whole state into a more active surveillance mode, going out and looking for the cases by increased testing and talking to providers. You have to test for HIV to identify the cases, especially in a community, and I think this is still true to Louisville to some extent, and Kentucky, where the needles and the drug use aren't associated. That's not a thought that occurs to people. Everybody says, oh yeah, you can get it from sex, but not from needles. And we do try to prevent infections and transmission by using the syringe exchange, and that's part of the solution, but it's not all of it. And I think another factor is that the syringe exchange are new to Kentucky, but well established elsewhere. So this one-to-one versus the multi-use needles, I don't think that's a debate elsewhere. I think that's one Kentucky's still having, maybe because it's still new here. So I want to talk to you a little bit about dealing with law enforcement. There have been, this was important for two reasons. The police are often the first responders along with the paramedics, but often the police get there before EMS or the paramedics. So they've all been trained in the use of Narcan and use it in the field. And basically what's going to kill you with a heroin overdose, I mean, AIDS might kill you ultimately, but what's going to kill you quick is if you stop breathing. And the Narcan, basically if you're gray and blue in your extremities and you're not breathing well, you need Narcan. That's just kind of the modus operandi for the police and the EMS. Legislation does permit the syringe exchange, and the participants in the syringe exchange can legally carry needles so long as they declare them prior to a police search. They can still be considered, they can still face misdemeanor charges. And then there's some funny things that happen related to this. In the last month and a half, we've had a TB patient busted by the police for supposedly having paraphernalia with their TB meds. They thought they were, so she went to court and I believe she got off. And then we talked earlier about other issues that go along with law enforcement. I mentioned to you that our counselors were certified drug and alcohol counselors. And across the river, well, across and up the river in Cincinnati, their exchange program manager was arrested for possession of drug paraphernalia in August 2016. She reportedly had an uncapped syringe and burnt cotton, which is part of the use mechanism, in her vehicle. And she was a former user who had been through recovery, and she was managing their program. And that's one reason we think it's important. We don't want anything to really tarnish this program, and that was one reason that the ISHED license here, it should be certified alcohol and drug counselor, staff that program. There is, however, some, I wouldn't necessarily say so much here in Louisville, but there is certainly some pushback from law enforcement about the syringe exchanges. And this was, Addiction is a big medical journal, and they surveyed 111 of the syringe exchanges. And about a third reported that the police confiscated the syringes. 26 reported police visits, and not like you're invited, let's teach you about how syringe exchange works, but to visit it. And 12% reported client arrests on a monthly basis, and those who were people of color were almost 4 times more likely to report the arrests. So issues with our testing here in Louisville. Clearly we need to refocus to reach our highest risk populations, the people who inject drugs and the MSM, and I'm going to be talking about some of the issues with MSMs. With the drug-using population, they're hard to reach, and the issue becomes, where do you go? Do you go to the ER where they are overdosing, or do you want to try to go where they're using on the street, or do you want to go to treatment programs to focus on the testing, or maybe some of each? We've started to use the Narcan administration maps provided by the police, provided by EMS to focus where we do our outreach for it, and we're trying to hire an MSM outreach worker with specific abilities to enter the bathhouse so we can prevent the cases. And here's what the issue is with that. If you're going to go into the bathhouse, and Louisville is a bathhouse, we're going to talk about that, you have to be a man. You're not going to let a woman in. So there's issues with how do you do the recruiting, and let's just say it's been an issue for Metro to get the appropriate job description done and to get that person hired. This is our Narcan map for the first half of 2016, and this is where the police or EMS had used Narcan at least 5 times, so 1 dot equals a 5-time use. And we're working on that now to further focus the testing where the use occurs. And then we talked a little bit, you've heard me preaching about opt-out HIV testing. Since 2006, CDC has recommended routine testing, and the idea is that you want to adopt a consent form that says, this is a test, if you come here, you sign the consent form for treatment, this is what we test you for. And it should be ideally between anybody who's aged 13 to 64 years of age and all pregnant women. And basically you're saying the HIV test will be done routinely unless you explicitly refuse to take a test. And that's very different than what is often the case now in Louisville. You have to ask for it, or there's a separate consent form. And this approach eliminates the requirements for pre- and post-test counseling. You're giving informed consent, but you're giving it to a list of tests. And it can also associate the stigma associated with HIV testing, because if everybody's getting tested, it's not as big a deal. And the way to think about this is, if you go to the emergency room or you go to see your doctor, they're going to take your blood pressure, basically, and they're probably going to draw blood for whatever. So this just becomes part of the panel. And very few places here, including the emergency room, the drug treatment programs, or the jail, do the opt-out testing. Right now, we've tried to implement this at the University of Louisville in their ER, and Norton's got the same issue. What we want the ER physicians to do is to put it in the electronic health record. That's a standing order, you click it. And they don't have any problem with doing it, but there's concern about who gives the results, and we're trying to work on that with the state now. And then the drug treatment programs, each establishment requires a different approach, and in jail they're only doing voluntary testing. And to give you an idea of why these are risky places, and we should be doing HIV testing, the University of Louisville ER has about 200 patients every day. 20% of them are drug overdoses. Corrections, 90 to 95 people a day are admitted. We probably test 10 a week. And in terms of drug use and people who are seeking treatment, this is based on interviews we did this summer. A minimum of 500 to 600 people are seeking drug treatment every month in Louisville. And to give you an idea of how much of it is out there, we work with Walgreens and the DEA and the police to do drug take-back programs. I think it's once a month, it might be every other month. And the most recent one that we did in October netted 953 pounds of opioids on one Saturday. They've had another haul where they took 60 boxes back in a day and then gradually got them incinerated. So these are all, I would say, people who could benefit from HIV and Hep C testing. And then we have an issue of federal funding. Right now, CDC gives Kentucky as a whole $2.3 million. The Ryan White money, which is basically what pays for treatment, not for drug treatment, but for HIV if you're HIV infected, is $13.4 million a year. And then SAMHSA gives, which is a drug treatment program, or from the feds, gives $1.3 million. But that funding is all flat. So the question becomes, how do we fund the testing? There's a new federal law that permits federal dollars to be used for syringe exchanges, but there's no new funding. So you have to shift money around. And we're currently in the process of applying for a grant from Gilead to fund expanded testing within the drug treatment programs. And depending on which test you do, the HIV testing can cost $8 to $12 per patient. So it's not a cheap thing. And because of the drug issues here, our initial focus is on the drug treatment programs. We're starting with the Moore Center and JDAC, and then to expand from there. And so that's kind of where things are with the drug-using population, but we want to talk about the men who have sex with men here. Most of the detected HIV cases are still in men who have sex with men. Younger men may be unaware of what their HIV status is, and this amazes some people. There are some who want to be infected for the benefits. They think they get it over with, and they'll be able to get on HART and the other programs that they get it, so some want to get it. And then I think there's recent stuff that talks about whether or not a newly emerging risk group among MSM is those who are on PrEP. And PrEP is pre-exposure prophylaxis for HIV transmission. You're in a high-risk group, so you're on it to prevent transmission, but then they go out and engage in even riskier behaviors. And that's something that's, I'd say, really starting to get some attention in the last 6 to 9 months. And then we're going to talk about bathhouses, because we have one in Louisville. So the history is that California passed a consenting adult sex bill that made gay bathhouses and the sex that took place in them legal, so that they wouldn't be constantly busted, for lack of a better term. And then in the mid-'80s, AIDS forced the closing of the San Francisco gay bathhouses. There were limited what sexual practices could go on, and it disallowed renting of private rooms so that sexual activities could be monitored as a public health measure. And you can see some issues in that. There are people out there having sex and the health department's looking at them. So that wasn't so popular. And today I want to talk a little bit about bathhouses. There are approximately 200 bathhouses in the U.S., and among the cities that have them in operation include Louisville. And there are people in Louisville who are very surprised by this when you say this to them. They're like, and that has included some people at the health department. This is the establishment. It's called Vapor Spa. And so and this is it's a policy thing here. STD and HIV are clearly spread during sexual encounters. Many of the bathhouses, including this one, have anonymous sexual activity where you're going to have multiple partners in a short period of time. There may be drug and alcohol use that occurs, perhaps not in the facility, but certainly with it. We talked before about the high-risk behaviors, receptive and anal intercourse. That's going on there. And the venues frequently do provide condoms and latex gloves and lubrication. How well taken up that is not sure. And then the HIV and STD outreach workers who investigate cases do visit the bathhouse, but we don't have the HIV prevention worker, which we'd like to have. And then the other issues get into internet sites and chat rooms, and we'll talk about that in a little bit. So the major issues related to the MSM here and HIV are that syphilis is a risk factor for HIV because those open lesions provide an entry portal for HIV, and syphilis elevations or outbreaks are considered a warning of possible HIV outbreaks. And we've had a 20% increase in syphilis in the last year, mostly among MSM. Louisville is considered a destination city for the gay community in terms of a lot of people want to travel here. For that, it's a welcoming community, but and there's an increasing mix that we're seeing of people who are both MSM and doing the injection drug use. And to give you a recent example, in August 2016, we had 21 syphilis cases. 86% of them were men who have sex with men. So the argument about bathhouses. Some anti-bathhouse groups argue that it's virtually impossible to monitor sexual activity inside, which is probably true, and that closing bathhouses may force men into unsafe or illegal situations in public parks, and that was what the situation was back in the 60s, 70s, 80s, and even in some cities now. And so basically they're picking up people in public parks and in lavatories with multiple partners. The counter argument can be that bathhouses are a major source of safer sex information and HIV testing and counseling. And what cities have chosen to do varies widely. If you go up in the east, on the East Coast, there's the effort to outreach into the bathhouses, but there's not much regulation. On the other hand, out in California, Los Angeles County enacted a bathhouse regulation with inspection back in 2004. It survived a court challenge, and it's on the books now and is enforced with inspection. Another issue is that the bathhouses often tend to be the guys who are in the closet. Either they're men who are not admitting that they're gay, or they're in a marriage or whatever, and so they travel and they go to the bathhouse, and it tends to be older. And the younger men often now find partners on internet sites. Some of them are Grindr and Hornet, as an example. And then this is our transmission in Kentucky for HIV cases. And for men, you can see the big risk is MSM, some IDU, and in women it's slightly different. There's a higher percent, it's about 8% that is IDU, and the other is heterosexual. And there's also health inequity that comes along with HIV and AIDS. The rate of living with HIV compared to white males, black males, it's 5.4 times greater. Hispanic and Latino males, it's 2.7 times greater. And for women, black females, it's 12.2 times greater. And for Hispanic females, it's 6.4 times greater. This is an estimated, came out this year, and it's estimated in where people have, what the percentage is. And let's see, there's where we go. So we're not the highest, but we're not the lowest either. And then to give you a context of where we are, ever diagnosed, we've had 4,227 HIV cases, and 2,700 are considered to be still living based on the surveillance that they do with vital statistics. However, the question is how many are still undetected. So in summary, HIV is an established disease with new epidemiologic twists. You can't find out what you have if you don't test for it. We need to do more active surveillance. It should be done in the hospital, ERs, and drug treatment programs, and jails. Kentucky counties have been identified as high risk for HIV outbreaks related to the needle use. And MSM remain a high risk population and need more surveillance and prevention efforts. And that's it. Thank you.
We have time for questions.
Very educational presentation. In the early days of the AIDS epidemic, New York City and other large metropolitan areas offered free HIV testing to anyone who walked in, anonymous or otherwise. What is the situation now in the Louisville area for HIV and hep C?
There's a couple ways that works. It's free at the it's free at our STD clinic. There are also specified outreach programs at specified times where we go out and do testing. And there are other community-based organizations, specifically Volunteers of America, that also does outreach for testing. So we probably need to do more of that. But I'm much more interested in trying to do that kind of focused testing among the high-risk groups. And we had HIV testing day in the spring, and I think we tested, 60, 70 people at the health department, and we had one positive. Back in the spring when they had the Gay Pride Parade, there was testing done that weekend, and I think they tested 350, and they got 2 or 3. So I like the idea of free testing and access to it. I think we need to do a lot more focused testing.
What is the false positive rate in the screening test?
It's going to depend on which test you use and what sequence and what the prevalence is. That's a whole series of calculations.
Okay, and then, well, I don't know what the tests that you use across the street are or regularly in Louisville, but do these tests take days for the information?
No, we've just done one with the lab where you can have your preliminary result in a minute. And on average, if we do like testing in the TB clinic or the STD clinic, you get results in 20 minutes.
You mentioned the cost of HIV testing in the clinical setting, like hospitals and emergency rooms and so on. But doesn't the Affordable Care Act mandate that preventive services be free? So
I don't know the ins and
covered
outs
by
of that.
insurance?
I'm not even going to try to address that one because there's a lot of ifs, ands, or buts in that. And the $8 to $12 is a range of what it costs to provide the test. But just because it's supposed to be done doesn't mean that they put it into the electronic health record, and doesn't mean that they've been through the medical affairs committee and the practice committees to do it. Yes, ideally, but the devil's in the details, and there's a lot of details to get the testing done on an active basis or an opt-out basis. And I mean, the state health department has been over in eastern Kentucky, in Hazard, and places like that, trying to get it done. And Dr. Yaffe, who we work with, and she's running into the same thing that we're doing here. The other place besides the health department that's working with Gilead is Norton, and they're running into the same thing. They wanted to put it into the electronic health record, and administration / the lawyers have put up some roadblocks. So it's not as easy as it looks. And the woman who's been doing the work for the state health department is an ER physician who came from Atlanta, and their version of the public hospital is Grady, and it apparently took them 3 years to get it established there. It's up and running now, but it was a battle. Thank you. Yeah. Mm-hmm.
This is sort of a random question, but I was out walking / running one day, and I found a needle, and I thought, oh, I'll just take it to the needle exchange and drop it off. I thought I was doing the right thing, but they looked at me like I was an alien for doing that. What should someone do if they find a needle?
I think that depends on a lot of things. You don't want to. You want to pick it up and bag it and make sure you're not exposed to it.
Yeah.
But let me tell you the range of things that's happened with that. We had somebody who was out doing volunteer work, cleaning up a park, and got stuck when he reached up into the fork of a tree. And so the city councilman sent him to the health department, and we sent him to the ER so he could get post-exposure prophylaxis. We've also got an issue, knowing that that's an issue. Everybody who comes to the syringe exchange gets a Sharps container that they can get rid of their needles in. And we've got 2 big fire engine red mailboxes, for lack of a better term, that are in the health department now, that we're in the process of putting out in the community so that people can dump the syringes in them. We have to figure out where they're best located in terms of that Narcan map that we showed you, and then how we're going to get the needles in and disposed of.
I was also like a nervous wreck driving to here. If I got like pulled over, would that be considered paraphernalia?
If a cop pulls him over, I would just tell him what happened.
Okay. I was just curious.
Okay, if you find
And tell him you're not a TB patient.
The best thing to do is pick it up with a pair of tongs and put it in like a heavy plastic bottle, like a detergent bottle or a soda bottle or can or something, and then just put it in the trash can.
Oh, you just
You can just throw it away. Yeah. So don't take it long distances. But if you did get caught, you're allowed to the needles you're allowed to declare. If you say you have it, you don't get charged for it in possession because they don't want their officers getting stuff. So you would have been fine.
Before they search, you have to declare.
Yes.
Not after. After too late.
And if you want printouts on that, it's on our website. If you guys have family members that have some questions on how to dispose of them properly.
Thank you.
Joanne, just a question. Are the addiction treatment centers in the area fully saturated? Are there sufficient services?
No, there are not sufficient services.
They're not.
If there were 2 things happen. One is that they're frequently on diversion, meaning they're full. And if you talk about the healing place, You have, to enter any program, you have to go through detox first. And at the Healing Place, they have half of the people who go into the detox go back out onto the street rather than entering the program. Part of that's availability, part of it, some of them aren't ready for treatment. The other thing that Louisville really does need to grow up about is what's the range of treatment. And part of this is related to the Affordable Care Act, I think, in terms of abstinence only, which is basically we're going to detox you and then give you some counseling and you're going to be able to resist. Basically, it's the Alcoholics Anonymous model applied to drugs. Was really all that was really viable, I think, until the Affordable Care Act was passed, because if you start on middle class and you're not poor, well, how are you going to afford it? And medication-assisted treatment, the Vivitrol and the methadone clinic, because we have a methadone clinic called the Moore Center, are completely accepted and tested ways to deal with people who have become addicted to the drugs or substance use. And it's very difficult to get people to understand it. And I think it's honestly kind of hypocritical, because think about who you know. And I guarantee if you don't have somebody in your family, or you don't have a friend or a neighbor or somebody, you've got people who have the problem all over Kentucky and certainly all over Louisville. But yet when we want to put a drug treatment center in, there's a hue and cry, not in my backyard. Well, maybe not in your backyard, but I bet you there's somebody who's using it in a bedroom nearby. It's just hypocritical. And Dr. Moyer's worked on some stuff with the Planning Commission recently, and I think it's about to go to Metro Council for an ordinance that any drug treatment facility be regulated as a medical clinic so that they can't be singled out. And to give you an idea, our Moore Center is down on the south side of town in this former bank building that looks like a square box, because it is a square box. And we're in the process of moving our STD or specialty clinic back downtown, and so we were looking for a space, and we found a space, and all of a sudden all of the, I wouldn't say all of it, some of the city council people were concerned that we might be putting the methadone clinic back downtown. They didn't mind it if it was the STD clinic, but it was the methadone clinic that was a problem. Never mind that it was about 2 blocks from the gay bathhouse.
You mentioned about the idea of observers being in the gay bathhouses and so forth and so on. And I don't know much about bathhouses, but I've been to other gay venues, and it bothers me when straight boys turn up in what's supposed to be a safe space for gay men. And they're in there for the purpose of some sort of missionary work, whether it's...
Well, it's not necessarily missionary work. It's more like, please don't get infected, and we can do HIV testing and condoms are available. I don't think it's fair. It's not missionary work in the sense of if you're trying to keep somebody from becoming HIV infected and you talk to them about what the practices are. Granted, the sex is probably still going to go on, but in most cities, the responsible bathhouses have made, and the one here has too, made available the condoms and the HIV testing. And I think we want to be appropriate for the people who are using the services, but we want to reach them. And what I really don't want to do is send it all underground, which is what it was before California passed the law. But the regulation of the bathhouse is going to be an issue here.
Is there any information from the states that have legalized marijuana use about whether IV drug use goes up or goes down?
I haven't seen anything yet. There's been more effort, and I'm thinking specifically of Colorado and Washington and Oregon now, about in terms of making sure that kids aren't getting the opioids, and especially in the foods, that the marijuana-infused foods or the candy, and the driving laws. I haven't seen anything yet about marijuana and it as a gateway to other drug use. I know there's that kind of research underway, but I haven't seen it for those 3 states.
Sure, I'm just curious. curious in terms of specifically the rural arena of Kentucky, and as you're pointing out, just utilization, injection, even specifically say among multi-generational, especially out in rural communities, how open, as you said, people are really in many ways naive. How open have you found, if you've had something on your interactions, have you found individuals to be out in those communities for just the educational aspect of what does this behavior mean and what are the repercussions?
I think there's more awareness of that, and I think that in the smaller counties, and Sarah, you may know this, how many syringe exchanges there are in Kentucky now. I mean, ballpark, I want to say it's up.
612,
Yeah, and so, and we keep hearing about more all the time. So that's part of it, but the other part of it is what kind of education has been done among physicians and treatment programs to make people aware of it. And one of the issues then, I mean, when I talked here about the lack of drug testing here, it's not just here, that's across the programs in general. SAMHSA has something called the TEDS data, which is treatment episode data, and then there's a discharge one. And they take a look, depending on the year, about how many of the drug treatment programs, and now we're not talking about the abstinence, we're talking about, it's one of the medication-assisted programs, test for HIV, and the percentages declined. It's maybe 20%.
It's a double edge. And there's two issues there, like you said. It's not just the individuals, it's the methods of how you get that
Yeah,
out there.
yeah.
And they develop that rapport.
Yeah.
So that people feel safe in order to receive the information. So how do you get the deliverers of that information on board?
I think there's a couple efforts underway. The State Health Department has a program where they're going to be taking out a mobile truck/van and going to different cities to push out the Narcan and the idea about this is what you can do to prevent. And that's part of it. And I think a lot of more community-based organizations like the Volunteers of America are starting to push that. And there's also efforts to put in really effective drug education programs into the schools. I don't know how many of you have ever heard of a book called Dreamland? But it's kind of it's a nonfiction book, and there's stuff about how the drugs are delivered is out of date. But it's an eye-opener in terms of how much of this stuff developed along the Ohio River Valley. The pill mills originated here. And there's another thing called SOAR, which is Save Our Appalachian Region, and I don't.
Yeah, I'm familiar with that.
Yeah, and they're the other ones who are doing a lot. Thank you.
Thank you very much.